of many research projects. Presently, he is a part of DBT Canine Research Center and working on the project elucidating the etiology of chronic gastroenteropathies in a dog. He has an excellent scientific career, evidenced by his quality research and clinical papers. He has published more than 70 research papers in national and international journals. He guided 10 MSc and 2 PhD students and attended various international and national conferences, seminars, symposia, and presented more than 70 presentations in the conference. He is instrumental in creation of Hindi version of Claw Health Atlas for International Committee for Animal Recording, Indian Council of Agriculture Research. He also standardized fast localized abdominal ultrasonography of horses, that is FLASH, for diagnosis of equine colic cases. Recently, he standardized transtracheal wash and bronchoalveolar lavage techniques for diagnosis in respiratory problems in equines. He also established endoscopy for diagnosis of upper respiratory tract diseases of equines at the University Hospital. He bestowed with many prestigious national and international awards, recognitions, honors, and especially mentioned University Best Featured Award for the year 2017-18, and many more awards and many Best Paper Presentation Awards to his credit. So I welcome Professor Dr. Swaran Singh Randhawa for his presentation on the topic ultrasonography in cattle. So I request Professor Dr. Swaran Singh Randhawa to start his presentation.
Thank you, sir. Thank you, sir, for a sweet introduction. So I welcome all the delegates. And the topic on which I am going to talk is very, you can say, good, because nowadays this topic is very well used in veterinary practice, because the previously when the topic started, the people start working on this, it was used for only, you can say. So this topic is very well used today, because there's very much implications of this ultrasonography in our bovine practice especially. And how I started using this ultrasonography, that one of my students did some work on measurement of sole thickness with ultrasonography. Previously, the people from surgery were using this. But when I standardized that sole thickness measurement technique, so I start using this technique and I see wonderful results with this. So then I changed my mind. For the last now 10 years, 15 years, I'm using this technique. And now, what are the advantages it has? Something about basics we will talk first of all, is better contrast resolution, then acquiring slice images of organs in different planes in the real time, then portable and non-invasive. So it is not going to harm anymore to the animal. If we see the physical properties, we know that ultrasound waves are those which are beyond the frequency, which in the perception of human ear. And the number of repetitions of this wave means frequency. We measure that cycle per second. 1 cycle per second is 1 hertz. And sonography in veterinary medicine, we use mostly 2 to 10 megahertz frequency. And the wavelength is distance covered by 1 sound wave during 1 cycle. So that determines how much penetration will be there. Because if we see this is the, you can say, low frequency, this is low wavelength and high frequency, and this is high wavelength, low frequency waves. So similarly, this wavelength and frequency are inversely proportional. If we take a low frequency probe, we can go to the deeper tissues. So because it has a larger wavelength as compared to high frequency probes, which we can say go on to the just minimal, you can say, depth. So this velocity in the mother tissues is depending upon two things like frequency and wavelength both. So velocity is always constant. Now, frequency mostly we select according to the desired depth of organ. So if we want to see some deep organ, then we have to select low frequency. If we want to see the superficial organ, so that is why most of the linear probes, they have you can say high frequency, because they go to the minimal depth. So there are four things on the basis of which we can see that ultrasonography works. So these are the four uh, means interactions with the tissues, that is reflection, refraction, scattering, and absorption. If we talk about reflection, reflection actually it is the basis of ultrasound image, because if there is no reflection, because reflection is, as the name indicates, because when the pulse echo goes from the machine, that will reflect it back from the tissue, and that determines that how the image will be created. So if we take two tissues of different, you can say, densities, so that means the reflection of pulse echo from the two different tissues will be different, and that is how we can differentiate those two tissues. So the proportion of reflector sound waves, that is a function of acoustic impedance. Acoustic impedance is depending upon the tissue velocity and the more on the density, tissue density. So amplitude of the reflecting echoes, that depends on the difference between the acoustic impedance between two adjacent tissues. That means if two tissues are adjacent with different, you can say, densities, or because if they have different density, they have a different acoustic impedance, and that mainly, you can say, uh, decides about the amplitude of reflecting echoes, and that decides our image, and that decides our resolution of, or the difference between two, you can say, tissues. Now, larger the difference, the more the waves that are reflected. So smaller the difference of acoustic impedance between abdominal soft tissues, that allows more waves to be transmitted, and that allows imaging of deeper tissues. Because if we go from a tissue which is less denser, as compared to if we go to the other tissue which is more, suppose if we see the bone is more dense, so all the, you can say, pulse echoes are reflected back. So these reflected sound waves, they help to image the boundaries between organs or lesions, due to which, if we have a, suppose if we have any fibrosis in the liver, or it is a circumscribed fibrosis, so we can easily differentiate it from the surrounding tissue. So another thing is refraction or deflection. That is refraction. Mostly we know is the principle of light on passing from one medium to another. There's the direction of the, you can say, sound wave gets changed, and that change in direction of the transmitted sound wave, they may create some artifacts. Whatever the artifacts we get in while doing this ultrasonography, we get because of this refraction. Third thing very important is goes or hit the tissue, there is redirection of sound waves in unpredictable directions by different, you can say, rough surfaces and the different types of tissues, and that scattering that allows the imaging of tissue parenchyma in addition to the organ boundaries. Fourth is absorption. Absorption, you can say, this is the cause of a. So whatever with the, what is the power, what is the amplitude of reflecting, you can say, pulse echo will be there, which is going towards the tissue, and what is reflected back, that is attenuated, because that is not full, you can say, strength as the pulse echo is. So that because there is there's absorption of some of the there's absorption of some of the these you can say sound waves, and that produce heat. So heat, if we see the frequency, according to frequency, heating increase as the intensity and frequency increase. So this is graphically is the reflection. So more, this is deflection or refraction, and this is absorption, and this is scattering. So if we say this picture, this is the electrical impulse that will go down the tissue through the probe, and this is how this take this path, and this is reflected back and go back in the similar pattern and go to the monitor to produce a image. So this is how this is reflection works. There are different kinds of probes also. There are, I don't want to take more time on this section, because there's a lot many things to talk to you about ultrasonography. So there are different types of probe: real-time sector scanner, sector shape or triangular shape, then linear probe or rectangular images there. What are the theory of image producing is that old scanners were mechanical, in which there is oscillation of or rotation of the crystals is there. But nowadays these crystals are stimulated with the help of electrical supply. So these are different types of probes: linear, this is curvilinear, and this is sector scanner, this is phased arrow, which is mostly used for the cardiac, you can say, functioning. So these modern probes, they work with the help of these uh, crystals, which don't move, but they are fired electrically, or they are stimulated electrically, and they produce arrays. So arrays formed in different configurations: linear, curvilinear, and so curvilinear probes. Mostly in Bovine practice, we use curvilinear probes and the linear probes mostly. So these phased array, if we want to continue with the echocardiography, so we can use in those cases, because they produce, you can say, big, you can say, width of the image. Instead they are peaking inside just ribs. So that is why it is called phased arrays. So they are very much used in the using cardiac studies or echocardiography. So sector scanners, they are of limited use as compared to linear or curvilinear arrays. So they allows the evaluation of deeper structures and structures for which the window of examination is limited. So they are especially sector scanners mostly used in the, you can say, dogs and cats. So in Bovine medicine, we commonly use this linear or curvilinear probe, especially with this much of, you can say, 3.5 to 8 megahertz frequency. So this is the, you can say, type of image also you can see. In the linear probe, we get this rectangular image, and in the, you can say, phased array, we got this triangular image. Or in curvilinear, it is more of triangular, but it is trapezoidal mostly in the phased array. So in curvilinear, mostly it is, you can say, it is triangular one. Now, image control, we use different types of methods. We use B mode, it is the brightness mode we usually used in most of the function. But if we want to see any moving object or moving organ, like heart, if we want to see, we use M mode. That is called motion mode. Or in the all the for all the, you can say, stationary organs, we use this B mode. This displays images of the elements of the image according to a gray scale. So uh, from the organ where the reflected echo will come late, that will be of poor quality. That is why, and that will be show away from the, you can say, probe, away from the starting point. So level of grays and the intensity of brightness of the image dots depends on the amplitude of reflected echoes, and tissues that transmits most of the echoes, they they are shown hypoechoic or darker, and tissues in which most of the reflected most of the echoes, that is they are mostly seen hyperechoic. So this is the pattern how if we see the fluid, so that is mostly black in color on ultrasonography, and muscle is less, you can say, it's more of, you can say, more of echoic than fluid. Similarly, as we move from the fluid to bone, so the high echogenicity increases, and in the bone it is all of, you can say, white will be seen when we, you can say, ultrasonic bone. So so the whatever the, you can say, uh, tissue density, if as the tissue density increases, similarly the more of, you can say, the more of the, you can say, sound waves are reflected, and there is lot of, you can say, echogenicity in that tissue. But except air, where air mostly it shows the hyper echogenicity, because it produces artifacts according to that. That means if you see air in between the, you can say, parietal pleura and the, you can say, this visceral pleura, so that means there can be, that can be a case of pneumothorax. So this is how we can say this is the hyperechogenicity, isoechoic, and this is anechoic. As high reflection increases, hyperechogenicity increases. As transmission increases, the echogenicity, anechogenicity, or the, you can say, less echogenicity will be there. So if organ of interest is deep, then the returning echo is strongly attenuated, and the resulting image of poor quality will be there. And then we can improve this thing by two things: by either increasing the, you can say, amplitude of emitted ultrasound wave, that is power, or amplitude, the signal of returning echoes, by just, you can say, gain. There are two types of gain: global gain, differential gain. So in overall, we can see that this global gain causes a uniform amplification of all the returning echoes, but differential gain, it causes the, you can say, amplification of those echoes where we want that these tissues should get more powerful or more clear. So in nutshell about this, then M mode, for Bovine cardiac assessment, we use motion mode. So this decides about the temporal changes in echoes, and with depth of echo producing interfaces on one line is displayed, and along the other line time is displayed. According to the time and motion, both are they are you can say, plotted against the x and y axis. So that is why, that is how we use this M mode. This is very good for nowadays. We make a revolution in this echocardiography. So recording of motion of interfaces towards and away from the transducer is then possible. And this mode is particularly used for cardiac chamber and wall measurements. So echocardiography, we see this is how we can see, this is the, you can say, in interventricular septum, and this is the left ventricle, and this is the right ventricle, or other way around. So this is right ventricle, and this is left ventricle. Now there are different types of artifacts. I think artifacts, I will just, you can say, just pass on these artifacts, because there are different types of artifacts we can use for image production, and we can also differentiate it from the, you can say, nothing is there. So external reverberation artifact is one which is very common, and there's production of multiple echoes from the multiple echoes from one ultrasound pulse bouncing back and forth between two or more highly reflective structures in the axis of sound. So the external reverberation is air between probe and skin, because there should not be nothing should be there between probe and skin, and that is why we usually want, then when we prepare the we can say prepare the animal for sonography. So the animal should be shaved properly, and there should not be any gap, and that gap should be, you can say, compromised with the help of gel. So internal abruption, similarly as in the large intestine, we have a lot of gas. So that is why these they reflect uh, in a different way. Ultrasound waves are reflected from that air, and they produce reverberation artifacts and also bones. See, you see this. This is the, you can say, reverberation artifacts in the colon, and this is comet shape. So these are both these are reverberation artifacts. So another is side lobe artifacts, and these generated images from the secondary beams are added to the one coming from the primary beam when they are reflected. Because when suppose this is the image, so we want to this just target this gallbladder, but see this is the thing where there is something extra is produced. So this is another thing. So this is artifact. These are the lines, hyperechoic foci. So these are the slide artifacts. When we see some, you can say, hollow organ with fluid. So in those cases, we get this side lobe artifacts. Then slice thickness artifacts. Then when hyperechoic parenchyma appears within the hypoechoic bile during sonography, or if we see the urinary bladder, or see this is the image. This is the image, and we see this this sludge. This is looking like sludge, but it is, you can say, this is artifact. This is artifact. So this is slight thickness artifact. And then acoustic shadowing will be there. Whenever there is something, you can say, mineralized or dense material, metal, wood, fibrosis, or calculus, wherever there is there, below that mineralized thing, there will be, you can say, shadow. And that shadow, this is a caustic shadow. So if there is something here which is hindering the path of, you can say, pulse echo and reflecting back, so that is why there is shadows produced. Most of the time this artifact is very much useful in cases of kidney renal stones, or you can say urinary bladder stones, or urethral or uretral stones. So these are very these shadows, we can use this shadow for, you can say, diagnosis of these urolithiasis or lithiasis in any part of the urinary tract. So then edge shadowing is there. So edge shadowing is seen distal to the lateral edges of round or oval structure. So it is caused by refraction of the ultrasound on curved surface. So if we see the curved surface, oval or round, so these ultrasound waves disperse in a random way and don't come back to the probe. So this is how that these waves pass down around the rounded surface of the organ, and these shadows, they are producing these shadows, and this is called as shadowing artifacts. Now for patient preparation, so every, you can say, patient should have, the area should be shaved and skin should be cleaned with water or alcohol. Caustic gel should be there to improve the contact between probe and skin. Then organs we can scan in the two ways, like sagittal. Sagittal means along the, you can say, direction of the organ, or transfer is across the direction, with goal of building a three-dimensional image in the examiner mind. So uh, it is very good for distinguishing nodular from the tubular structures. Now it is important to bear in mind that ultrasound is sensitive for evaluating tissue changes, but it is sometimes it is not so specific. So for example, if we see the respiratory system, some of the things, they're very good with ultrasonography, but the first test for means for chest infections or for pneumonia, or we can say the thoracic changes, that is radiography, if we could able to. But the limitation in boys is that elbow hinders the cranial part of that lung, so we could not image that part. So that is why where our ultrasonography uh, did work. Then coming to the gastrointestinal tract, so indications are traumatic reticuloperitonitis, ileus of small intestine, dilatation and displacement of cecum, perireticular abscess, peritonitis, left and right displacement of abomasum. That is not common here, but this is just for your information. So we use mostly this curvilinear probe having this 3.5 megahertz to 5 megahertz frequency. So we use mostly not linear, but we mostly use this convex transducer. Now, on the left side, we can start with the reticulum, spleen, rumen, and parts of abomasum. On the right side, we can see liver, amasum, abomasum, small intestine, large intestine, right kidney, and the uterus may be seen on either side depending on the stage of pregnancy. So, because sometimes it is more, you can say, suitable to see from the left side, or sometimes it is more suitable to see from the right side when the, you can say, fetus is more than, you can say, 7-month pregnancy. So it is more suitable to see from the right side. So if we go to the reticulum and rumen, so when I started this seeing this ultrasonography or using this ultrasonography, I started with the reticulum. So every clinician, especially the medicine person, they should know about the how you perceive, you the medicine people can perceive during ultrasonography, the other people cannot do that like that, because you have seen the case, you have seen the animal, you have seen the different clinical signs, you have auscultated the animal, uh, you have done clinical examination, thorough clinical examination of the animal, and I think you know where the problem is. And when you do ultrasonography, you will keep in mind that I am looking for this problems. I should confirm this much, or I should rule out these things while doing ultrasonography. So I think a clinician is more suitable to go for ultrasonography rather than other people. The mostly the reticulorumen recess is seen from the seventh intercostal on the left lateral thorax, or as well as we can see it from the left paramedian. So reticulum is seen in the sixth intercostal phase on the left as well as right lateral thorax. Then transducer is applied on the ventral aspect. Then normal reticulum, I don't go to this. So when we apply this transducer on the downside, this is a picture from the left sternal region or a left paramedian. So you see, this is a reticulum. So this is reticulum, and this is ventral abdominal wall. And now, if you see the reticulum, just is not visible in all the, you can say, this is an image taken from a book, not my own image. So this is how it is tunica serosa, and this is tunica muscularis and tunica mucosa. Tunica serosa, muscularis, and this is mucosa. So this is all reticulum, and this is diaphragm, this is musculophrenic vein, and this is fluid after, you can say, posterior to the diaphragm. So that means it is in the abdominal cavity. So for assessment of reticular motility, reticulum is observed for 3 minutes at least. Continuous, we have to keep our probe on the reticulum for 3 minutes without moving the transducer. So we have to see whether there is in for 3 minutes, for every 3 minutes we get this bifacial contraction of reticulum or not. So that is how, if it is if it is something like TRP or local peritonitis, so these contractions, they subside, or they will get hindered. And if there is something like reticular abscess, there may be, you can say, hypermotile reticulorumen is there. So this is our own picture, that is, we have seen it from the sixth intercostal space, and see, there's no clear, you can say, demarcation of different layers of the reticulum, but this is reticulum. We can visualize it from the sixth intercostal space on the left side. So, and from the left side, this is the, you can say, dorsal side, and this is the ventral side. So as we move down to the ventral side, the spleen, that is moving from the rumen to reticulum, and coming down to the ventral side, it tapers down. So spleen appears cross section as 2 to 3 centimeter thick and tapers down ventrally. The capsule of spleen, that is, this is the capsule of spleen. This is the capsule of spleen. That appears at echogenic line, and the vasculature of spleen is in the cross section. So see that this is vasculature. This is vasculature of spleen. So this is the normal spleen, and see, this is a blood vessel. So this is rumen, because it is seventh intercostal space, and this is, you can say, uh, splenic capsule. And one thing you keep in mind, that for cows, it is easy to go for this ultrasonography as compared to buffaloes, because in cattle, there is lot of space in between. Intercostal space is quite good in cattle. So we can easily, you can say, peep into the body this with this probe. But in buffaloes, there is overlapping of, you can say, these uh, ribs. So that is why it is little bit, you can say, difficult, but it is not impossible. It is very good. We can do ultrasonography in buffaloes also. Rather, I will show many pictures from the buffaloes studies. So in TRP, we have to see spleen, and then we have to see the reticulum, then we have to see the rumen, or we have to see whether there is something in between spleen and reticulum is there, or whether there is some fluid is there, or whether there is some fibrin is there, or whether there are some deposits are there, or whether there is some abscess is there. So we have to find out that. So see this picture. This is a spleen, and this is diaphragm, and this is a wall. So we are peeping from the left side. So from the left lateral thorax, we are seeing it. So this is, you can see the what is the amount of fibrin we have in between spleen and reticulum. So this is a fibrin. So this fibrin indicates that this is a case of TRP. Okay, and this is fluid. This is fibrin. Then this is another picture. The image is, you can say, in this case, the reaction is somewhat less as compared to the previous picture. There's a lot of fluid, but fibrin is less. And this is reticulum. Then coming to this picture, this is sixth intercostal space, and this is reticular wall. And again, there is fluid. And this is pleural effusion, and because it is anterior to the diaphragm, so that is, this is pleural effusion. This is again peritoneal action, post xiphoid. It is seen from the downside, or paramedian, left paramedian. So now, if we see the reticular abscess, they have echogenic capsule of varying thickness, which surrounds a homogeneous hypoechogenic to moderately echogenic center. So if we see the abscesses, mostly abscesses are often between the reticulum and spleen, reticulum and liver, reticulum and mesum, and reticulum and abomesum. So we see this picture. If you see this picture, this is the, you can say, abscess wall, and in the abscess wall you see this is homogeneous to moderately echogenic. So material in between, this is the abscess, and we can easily go from this very place, because this is mostly we see from the left paramedian or right paramedian, and we can measure this width, and according to this width, we can select the needle, or we can just, you can say, drain this abscess also on the right on the spot. This is one case I presented on one of the conferences also. So you see, this is the spleen, and in the spleen there is abscess, and we approach this, we able to diagnose this spleen from the eighth intercostal space. So we drain this spleen and see, after draining, we see it from the sixth intercostal space, and this is the splenic abscess, and this is spleen. So this is reticulum. So this is before and after drainage. So now coming to, this is cyst. This is splenic cyst, and again we can see it from the you can say sixth intercostal space also, and sometimes these cysts, most of the time in boys especially, this is a very, you can say, day by day increasing problem of hydrated cyst in boys. So because we mostly on the farms here in Punjab, people keep dogs on their farms, and these dogs, they put their shit sometimes in this wheat busa or the roughage or in the manger, so that can be a source, because cattle is an intermediate host and they get infected, and they got these cysts in especially spleen, liver, lung, or even sometimes perirenal area, or sometimes we have seen that these cysts are present in whole of the, you can say, peritoneal cavity. We have seen some cases where there are cysts in whole of the peritoneal cavity. Then this is a, you can say, cyst in the liver, because in this case when we were doing this ultrasonography of the thorax, so we got the cysts in lung tissue. So when we screened the liver tissue, so there were a lot of cysts there, and this animal was having lot of, you can say, wasting is there in this animal, and this lot of distress, respiratory distress due to presence of cyst in the lungs also. Then this is diaphragm. These are the cysts in peritoneum. See, this is diaphragm, and these are cysts are present posterior to the diaphragm. Now this is a kidney, and there is hypoechogenicity of the cortex, which is showing that there might be glomerulonephritis something, or these are the cysts in perirenal area. Then again, this is reticular abscess. Sometimes from the fifth intercostal space, we visualize by fanning the, you can say, probe towards the sixth intercostal space, and that is visible from this place, and there's about 10 centimeter diameter cyst is there. Then for abomasum also, we can see both the, you can say, left paramedian and right paramedian also sides, regions, and most of the abomasum is present on the right paramedian regions, but in the left side also it is present between this rumen and the ventral wall, or maybe the cranio-dorsal blind sac for rumen and ventral abdominal wall. So see, in the abomasum, how you will differentiate abomasum, that it will has folds. See, these are the folds. So from these folds, you can say that this is abomasum. Otherwise, because similar to the stomach and monogastrics, we have folds in abomasum also in ruminants, from which we can differentiate this is abomasum. So from the seventh intercostal and the left paramedian space, we can see that this is abomasum. See, again, this is abomasum, but in this case, you will see folds are not too much clear. And then uh, we can see this left displacement of abomasum or right displacement of abomasum, which is usually present in pregnant animals in the Western countries. But in our country, it is not the usual case. But I will show how you will see. If we show the cross section of the animal from you can say posterior side of the animal, so you'll see this is the right displacement and this is the left displacement of abomasum, and you will see most of the time when we go see peep into the 12th intercostal space dorsally, we go directly after this abdominal wall, we see the rumen wall. But in this case, you have a sac in between, which is having folds also. So this is the, you can say, abomasum. So this is left dorsal displacement of abomasum. So we can see. So in abomasitis or abomasal ulcers, we can also differentiate that this is a case of abomasitis or abomasal ulcer. How? Because type 1, type 2, we cannot, you can say, judge from the ultrasonography, but type 3, we can just see type 4 ulcers or type 3 but on the basis of the reaction in the, you can say, peritoneal cavity that because when there is type 3 abomasal ulcer, there is fibrinous traumatic reticuloperitonitis with abscession, and type 4 you will have ascites, fibrous adhesions, and thickening of the intestinal walls. So, and also one thing very clear, whenever there is type 4 abomasal ulcer, you may get the peritoneal fluid serosanguinous in color because there is sometimes bleeding also in the these ulcers. Then omasum we can see from the right side, right from the 8th intercostal space to 10th intercostal space. And if it is proceeding beyond that, so that means there is going to be confirmatory for a nasal infection. And along with that, you will also see the caudal displacement of gallbladder, which is also, you can say, suggestive of a nasal infection. And especially another thing is there is no contractility you will see, and there is you can say, here you can see this is the liver and this is omasal wall. This is on the right, you can say, paralumbar fossa, 11th intercostal or 12th intercostal, we can see this omasum. Then small intestines, mostly we see the small intestine from the, you can say, left anterior to udder place, left ventral anterior to udder place, and on the right side also. But we can also see small intestines from the 8th intercostal to the you can say right paralumbar fossa, from the dorsal you can say spine up to the ventral midline. So the right side, whole of the area between 8th intercostal space to the right paralumbar fossa, from the dorsal top line to the ventral midline. So that is also suggested to see for small intestines. So it is between the tubercocci to the 8th intercostal space, from the transverse personal vertebrae to the linea alba. Then what are the things we have to see? That the normal wall of small intestine, it is just 2 to 3 mm thick, and its luminal diameter is 2 to 4 centimeter. There is no difference between the diameter of small intestine before and after feeding. So the cranial part of duodenum is the close proximity. So this is the site of, I will show you where I will see the liver. I will show you where you will get this duodenum. So these are the loops of jejunum. This is a picture from the book. But if we, in our case, we have seen these. This is the liver, and along the liver, because this is a case of this peritonitis. In that case, we got this intestinal loops adhered with the, you can say, liver capsule also. And this is another, you can say, picture. This is another picture. This is liver, and this is the position of this duodenum also, because it is present between the, you can say, here it is omasum mostly, and in between the nasal wall and the liver capsule, you will have this duodenum here. So, but these are intestines, So see this picture. See, these intestinal walls are fully adhered, and there is loss of, you can say, totally loss of. This is a case of paralytic ileus, but because of peritonitis, secondary paralytic ileus, and uh, so intestinal loops are thick walled and adhered to, because it's mostly the thickness should be the wall thickness should be 2 to 3 mm, and the diameter also 3 to 4 centimeter, but it's more than it is not more than that, but walls are adhered. In large intestine, how you will differentiate large intestine from the small intestine? That you will see the marked gas content in that, which is not present in small intestine. In small intestine, you will see the movement of ingesta, but in the large intestine, you will see the marked gas content, and you can mostly see this cecum, colon from the left paralumbar fossa, uh, below the left paralumbar fossa on the right side in the mid-abdomen area. So you will see dilated cecum can be missed on the lateral abdominal wall, and especially mostly it is seen more visible behind the, you can say, 12th intercostal space, or below the left paralumbar fossa. So this is cecum, this is mid-abdomen, this is cecum. So here uh, this animal looks to be pregnant, because this is spine of the fetus. So now coming to the peritonitis. So there are a lot many causes of peritonitis, because faulty AI, foreign bodies, perforated abomasal ulcers, injection of irritants in the peritoneal cavity, rupture of uterus during parturition or dystocia, exploratory laparotomy, cesarean section, tokarization of 3 months. So there are a lot many things. So, but how you will see the peritonitis, that when you see the spleen, the below is lot of fluid, and sometimes this fluid is so much that it is totally, you can say, abdomen is a distended one, and it is pear shaped, and wherever you can see even fluid on the dorsal side near the liver also. So I will show you the picture in coming pictures. So this is another case that this whole of the, you can say, peritoneum is having hydrated cyst. So here you see, this is a fluid near the liver. So liver, this is liver capsule, and there is fluid with fibrin. This is fluid, fibrin. So this is peritoneal fluid, and this is again peritoneal fluid in the eighth paramedian right side. So this is also peritoneal fluid. This is just anterior to udder, left side. So that might be a case of diffuse peritonitis. I don't remember now, but that might be a case of diffuse peritonitis. Another thing we can see in the gastrointestinal system, that DH, we can confirm it 100% with the help of ultrasonography. We can see the reticular motility also. If we see the reticular motility in the thorax, in the third to fifth intercostal space on both sides, that means it is confirmatory for DH, or especially on the right side, because it is mostly in the adult lactating and pregnant buffaloes which are pregnant, and mostly the window, herniation window, is mostly on the right side. And on the right side, the reticulum covers the right ventricle, and otherwise on the right side, from the third to fifth intercostal space, a heart should be there, or a right ventricle we can visualize. But if there is DH, you could not able to find this right ventricle from the right side. So on the left side, the herniated reticulum, you will see adhere to the right ventricle and pressing the apex of heart. That is confirmatory for DH. Just see this picture. This is left ventricle, this is interventricular septum, and this is right ventricle. And this is reticular wall. So when you will see the heart pumping or contractions, the reticular valve will move along the heart beat. So immediately you can see this is a case of DH. Another is on the, you can say another picture, same on the left side. Now coming to the liver and gallbladder. This on the right side you can go for the liver. So this, see this picture of liver. This is more hypoechoic and having more of hyperechogenicity. So there's congestion also. The distension of gallbladder also. This is gallbladder. So we can easily see gallbladder on the 12th, oh sorry, 10th, 12th, 11th. 10th, 11th, and 12th intercostal space, and mostly in the mid abdomen on the right side. So see, this is my student which is doing this uh, uh, ultrasonography of liver and gallbladder, and we also collected from this place this bile for you can say isolation of causative bacteria in diarrhea cases. So this is how we can collect. Then coming to the respiratory system, although in the respiratory system, radiography is more competent, but ultrasonography is not, you can say less. So we can see a lot of things, we can clear a lot of things. Pleural effusion, superficial pulmonary lesions, consolidation, pulmonary atelectasis, then pneumothorax. So for craniomental part of thorax, this is very important because in boys, most of the time, radiography is not possible of the cranio-ventral part because of shadowing by the elbow. So that is why in that case, we can use this cranio-ventral, this ultrasonography. So it's more, and we can use this linear sectorial probe, but we use that same probe, which is we used for the abdomen also, the same one, 3.5 to 5. So we can use 7.5 to 3.5 also, but and we have to use each, you can say, intercostal space with very cautiously moving from the down to upside or up to downside. So from the 5th to 12th intercostal spaces, and we can see that visceral pleural lung surface form a hyperechogenic line, pleural line. I will show you, and you can see the gliding of visceral pleura because parietal pleura is fixed and that is just lining the thoracic cavity. So we can differentiate parietal pleura from the visceral pleura by real-time examination only. So you can see the air contained in the lungs, that is the, you can say, hindrance because sound waves, they want some you can say sound medium or solid medium to propagate. So in either fluid or you can say solid one. So that is more suitable if there is fluid in the thoracic cavity. So in that case, we can easily you can say diagnose any of the thoracic condition because the visibility of the lung and its other things, other you can say areas is become more, you can say more improved. A resolution becomes more good in that case. So if there is thoracic cavity fluid, then the you can say ultrasonography of respiratory system is more good. Then you can get common tail artifacts. Pleura is have irregular fragment appearance. Then if here there is fluid, so lesions that are located deeper in the lung tissue that they are not visible with the help of ultrasonography. See, this is the case where there is some air here and that produce hair. Sorry, this is not air. This is air. So that is why this is air. So which is producing reverberation artifacts. So these are reverberation artifacts. Then in pneumothorax, air in between will be highlighted and will be more seen more whitish type or hypercoic type. So how you can differentiate? Then we can differentiate bronchopneumonia if you have any fluid nodule just adjoining the you can say pleura. So that indicates this is a case of bronchopneumonia, and you will see the alveolograms, and they are for varying sizes and either hypoechoic or anechoic. Just see, this is the normal thing, and we are seeing the stram lines this is a pleura, we can see, and this is the ninth intercostal space right side. So see this picture. So these are the pleural effusions. So this is the visceral pleura and this is parietal pleura, and in between this is the fluid and fibrin reaction is there. Then see this picture. This is fluid and this is case of bronchopneumonia. Here is also this case of bronchopneumonia. You will see the alveologram. And this is another case where you will see the lung consolidation, because you will see this is hepatization of lung or liver-like formation of lung, and there is, you can say, heterogeneous hyperechoic areas in between with the interspace with the hypoechoic areas. So this is lung consolidation. Similarly, this is lung consolidation. So this is lung consolidation, and this is another picture from book. You will see this is hepatization of lung, and with this hyperechoic areas with hyperechoic areas. Now this is a pleural fluid in this lungs. So here you can say this is diaphragm, but diaphragm is totally, you can say there's lot of fibrin is there on the diaphragm. So this is a case of pleuritis, you can say, or pleurisy, where you can able to find such type of finding. This is spleen. Spleen is quite hyperechoic, and there is congestion also. And this is reticulum. Then another, this is pleural fluid with fibrin, and this growth. This cyst in lung. This is how, because cyst will be very much circular, and they are of different sizes, and there is also, you can say, some hyperechoic areas downwards. So reverberation facts are there. So this is, because it is fluid filled, that is why it is totally anechoic. Now coming to the cardiovascular system. In cardiovascular system, the diagnosis is very challenging, because clinical signs can be hidden unless there is congestive heart failure or unless there's more advanced stage. So prognosis is very guarded to poor. So echocardiography is very useful. You see, in echocardiography, we permit we can go for the cow-side diagnosis when clinical signs are not obvious. So we can just use this ultrasonography technique, and we can use this mostly low frequency probes, because they can go to the deeper extent possible, and we can use little bit higher, you can say, frequency probes, because in calves the body, you can say, thickness is quite less, and we can use high thickness. So limiting factor is narrow intercostal space, especially in buffaloes. In calves, so animal is restrained just like dogs in right lateral recumbency, and area from third fifth to intercostal space is clipped on the both sides. And then pericarditis we can easily see. So pericarditis is a lot of, you can say, because it's most of the time the cases with TRP, they move on to the pericarditis. It is mostly traumatic pericarditis. So most of the thing, most of the cases in boys we see like this. So because this is constricted cardiomyopathy after pericarditis, and there's a lot of fluid here. And mostly we use fifth intercostal space in these animals, third to fifth intercostal space, left and right, both we can use, but it is more visible from the left side, because it is heart is more of, you can say, lineated towards the left side. So that is why it is more visible from the left side. So here we can easily see this is fibrin, and this is fluid with the, you can say, I think in this case mostly pus is there. So because it is pus-like consistency. So this is interventricular septum, right ventricle, left ventricle. Then endocarditis, we can see any thickening, but that endocarditis we have seen very rare cases. Even in the my, you can say, previous 15 years, I have not seen any case of endocarditis here. So most of the time there is mural endocardium, and that gives the confirmation of vegetation or shaggy appearance of the that valves. So so this is how the area. These are the valve area where we get this. Then this is septal regurgitation. This right to left ventricle, and this interseptal regurgitation. Then this is pericardial effusion. This is a case where there is a lot of pus was there. So this is septic pericarditis. You will see with pus in the pericardium. This is pus, and this is wall of the posterior wall, left ventricle, aorta, interventricular septum, right ventricle. So then we can go for echocardiography, and in Bovine especially, although we can use this right caudal long axis view also, because we have to keep the knob of the, you can say, your face array probe towards the dorsal side. But in this case, we mostly use this method, that is short axis view, where we rotate it 90 degree towards the front of the animal or cranial side of the animal. So most of the time we use this short exercise on the right side. So this is this again. I think we have gone through this. This is the thing we can use with this M-mode echocardiography image in the healthy animal. So you will see in the case of pericarditis, you will see lot of fluid, and now another case where you will see pus, or another case where you will see fibrinous pericardial action. So we can also, you can say similarly, when we calculate all the things from here, so this is a right ventricular wall, right ventricular internal diameter, this is interventricular septum, then left ventricular internal diameter, left ventricular posterior wall. So this is how we can each and measure each and you can say every measurement at diastole and as well as systole, and we can calculate how much you can say end diastolic volume should be there. This is the formula for end diastolic volume and end systolic volume. So, and we can calculate the ejection fraction. The normal ejection fraction should be between 60 to 70%. And if it is, you can say below that, that means animal might having some problem, and fraction shortening. So we can calculate like this. And all the measurements, we have to use this right parasternal short axis view, and transducer should be perpendicular to the ribs. So this is another case. We can see the dilated cardiomyopathy. We have seen in one case in the cattle also. So this is how you can measure the internal diameter. Then we can see the valvular regurgitation with the help of this same method, but we keep our machine from the M mode to the color Doppler. So in the color Doppler, you will see two different types of colors. And if you have some green color, that means there is regurgitation. And we can use this for mitral regurgitation as well as septal regurgitation as well as tricuspid regurgitation. Coming to the urinary tract. So they are diseases of urinary tract, although they are very less common in Bovine especially, but they are not so much, you can say, less. So we have to differentiate pyelonephritis, urolithiasis, hydronephrosis, renal cyst, renal tumors, amyloidosis, cystitis, bladder paralysis, bladder rupture, bladder neoplasm, nephrosis, glomerulonephritis, and polynephritis. There are not many things we have to differentiate. And one thing you keep in mind, the biggest one is that you have to, if it is a chronic disease or if it is a acute disease, you have to differentiate both of them on the basis of just size of the kidney. So in acute stage, the most of the time size will be more, or it is normal size. Or in chronic renal disease, most of the time the kidneys, they get shrunken and they become atrophied, and they will be of small size. And there is in both these, you can say, chronic and acute diseases, you will have more of hyperechogenicity in the cortex of the kidney. So mostly we use 5 megahertz low frequency transducer, right parallel fossa for the, you can say, right kidney. And for the left kidney, we mostly use the transrectal probe, and mostly it is 5 megahertz. So we use for left kidney. For right, it is mostly right parallel fossa. So even then, we cannot, you can say, the cranial pole of the left this kidney cannot be fully visualized. So there are a lot many limitations in this also, because of big body of, you can say, our points. So kidney lobulation, you can see renal cortex will be hyperechoic compared to the surrounding tissues. So we can easily differentiate that this is a kidney. And medullary pyramids, they are less echogenic. So urinary bladder, we'll see. I think we should directly go to the pictures. So see, this is a kidney, right kidney. So this is renal pelvis. So I think this picture more clear will be there. So see this picture. These are the pyramids. These are the pyramids. It is quite, you can say, more echogenic, more less echogenic, anechoic. So as compared to this area, this is cortex. So cortex is lot of, you can say, more hyperechoic as compared to, these are calyces, and this is renal sinus. So renal sinus will be white. This is caudal vena cava. So this is a case of nephrosis. Mostly nephrosis occurs in long-standing diseases. So you will see there's sonography of right kidney, and there's hyperechoic round to oval structure casting strong shadows. So in any case, you will see this. So these are shadows, the acoustic shadows. So whenever you come across this nephrosis case, you will get the hyperechoic cortex, and there is perirenal edema also. And along with that, there are hyperechoic round to oval structure casting strong acoustic shadows. Then this is a very easy diagnosis, because if you get a cyst in the kidney, it is very easy to diagnose, because it is very much, you can say, hypoechoic as compared to the surrounding tissue, and you can easily visible with the help of simple, you can say, transcutaneous probe. So this is another case where there is urolithiasis, and this is a 1 month, you can say, bull calf. The renal calyces are dilated. This is pyramid. These are pyramids. This is cortex, and this is calyces. Calyces are dilated and filled with anechoic urine, which compresses these medullary pyramids, which they become smaller in size. Then this is, you can say, another picture in which there is, you can say, a sonography of, you can say, urethra between scrotum and the purpose. So while doing this ultrasonography, there's some hyperechoic mass is there, and when this after postmortem, it was seen. This was from one outside study in the Western country. So you will see this is the urethrolethiasis in a calf. You'll see this. Then this is another case of glomerulonephritis. You will see most of the time in this some whenever this long-standing disease, there is some immunopathological process which leads to neurological process which leads to this glomerulonephritis. And there is in acute glomerulonephritis, you will have renal enlargement, but in chronic you will have decreased kidney size, and there is distinct, you can say, hypoechoic medullary pyramids. So these are medullary pyramids. So this cortical echogenicity also increase in this case. You will see the kidney shape is also disturbed in this case. So this is a case of glomerulonephritis. Uh, this is another case where you will get cyst in perirenal area, and this is a urinary bladder. I think uh, this is a case where you will have right kidney hydronephrosis. So this is a case comes to us few months back. So this right kidney hydronephrosis and hyperechoic half moon shaped calculi cast this caustic shadow through the deeper tissue. Whenever there is urolithiasis, you will come across these type of shadows because whenever there is hindrance to the you can say pulse echo or through the body from the machine to so this hindrance will occur as a caustic shadow, and that will confirm our diagnosis about the any type of urolithiasis or uterolithiasis or cystolithiasis. Then and then in hydronephrotic kidneys, the collecting system is dilated, so hypoechoic and renal parenchyma is usually thin. We'll see this case. So this is another case where we'll find a urinary bladder. You see debris in urinary bladder, and there's urine. Actually, if urine is clear, that is more of you can say uh, is fully anechoic area should be there in the bladder. So, but in this case, it is debris. That is why it is more of you can say hypoechoic side. This is a case of cystitis in a buffalo. You will see the thickness. Most of the time, is thickness is zero point 0.5 to zero point 0.6 centimeter. So, but in this case, it is 1.46 centimeter. That is almost double or more than that. So, this is a case of cystitis in buffaloes. In uroperitoneum, most of the time in uroperitoneum you will have lot of you can say because most of the time uroperitoneum occurs because of rupture of urinary bladder, and whenever uroperitoneum will be there, so when you puncture you can give a puncture on the you can say abdomen ventral side with the help of needle. You will have fluid that is mostly urine, and you go for the you can say creatinine level of that urine that is almost double. So creatinine will be there, creatinine will be increased in the peritoneal fluid, so that confirms the uh, this uroperitoneum. So lastly, I have used this sonography for sole thickness also. So when we use this, we also standardize with the help of cadaver also. So first we took a cadaver and we measured this sole thickness with the help of sonography. Then we take its hoof and we just you can say cut that uh, hoof into two parts, and we measured, and it was more than you can say 90% correlation between our findings and the cadaver findings. So that is how we standardize this techniques. So if we are applying you can say just this probe on this side, that is sole side. So this is how we can measure this epidermis. This is the epidermis, and this is dermis area, and this is bone. So this is ultrasonography measurement for sole thickness. So this is how we can measure the epidermis. And in lameness, most of the time, what happens that this epidermis sole thickness that decreases a lot, and that leads to you can say puncturing of the sole or the soft sole or the abscession of sole, and maybe you can say introduction of foreign bodies from the sole into the dermis. And this is how we can measurement of this sole thickness with the help of ultrasonography, and we can decide also about our future plan of breeding also based on this, that we have to take only those animals which are having more epidermis sole thickness. So this is I think this is another thing that we can also measure distance from the bone also. So if you are not able to see this line, you can measure this also, and on the basis of that also we can select animals. So we can select animal for the breeding or we can just segregate the animals which are lame, because in that case, this epidermis or this area, this length or this width will be very less. So this is DP is distance from the sole up to the bone, up to the phalanx. Distance from sole to phalanx. So this is all about ultrasonography. I think I have taken a very long time. So because uh, uh, some of the slides I have to skip. So in conclusions, that so this ultrasonography is wonderful technique, easy to use, safe, quick, safe for the animal, safe for the person who is operator, and both operator and patient friendly guide for sampling, and also very good guide for sampling, especially the biopsy ones or FNACs. So we can take the deeper tissue FNACs for the drainage of abscesses, and this is wonderful techniques. We can also useful in field cases. I have not covered the reproduction part because that is another full you can study, because in that case you can even see the ovarian, you can say, activity, ovarian follicle size, ovarian follicular maturity time, and you can even see the corpus luteum, you can see the uterus status, you can see the cervix status, and even lot many things you can see. So this is a wonderful technique. I think every clinician must use this technique in future, or if he is using, is a wonderful man, of course. Thank you very much. If you have any question, you can ask me as many questions you can. Hello.
Thank you, sir. I request if there are any questions, kindly display those questions, please.